Hey everyone, Dr. Pat and I would personally like to invite you to join us in our Grow My Baby program. This is week-by-week pregnancy and birth information developed from our experience of helping more than 4,000 women grow and birth their babies. All our links are on our website, growmybaby.com.au.
The information in this podcast is provided for education and research information only. It is not a substitute for professional health advice.
If you're trying to get pregnant or you are pregnant and you feel a little bit overwhelmed by all you need to know, then this is the right podcast for you. Welcome to the show. I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney. And this is The Kick, your expert-led podcast that delivers the essentials of growing a baby. Make sure you head to our website, growmybaby.com.au, to get some awesome free tools like our pregnancy knowledge checker to help you feel like you got this.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today we've got a very special guest with us, Kath Baquie, who is a pelvic floor physiotherapist. Kath is a mum of 3 girls and she has an online community, Fitness Mama. Inside Fitness Mama, she helps to provide pregnant and new mothers with the exercises, support and resources they need to move from the overwhelm, the physical aches and pains of pregnancy, or the weakness felt before and after birth. Instead, she helps to replace that with the comfort and confidence they need to feel strong again inside and out so that they can get back to doing what they love with a bubba by their side, whether or not that's running around with the kids at the park or running the next marathon. Kath also has a podcast, the Fitness Mama podcast, where each week she dives into all things pregnancy care, childbirth and postnatal recovery, helping you to have a wonderful pregnancy and after birth experience. Welcome, Kath.
Thank you very much.
I love your podcast. And actually, Kath and I are online buddies. We met through Instagram, which is fabulous. It's just great to see an expert in this field come into a social media space and share so much information. It's really worthwhile picking up on Kath's content, either on IG or on her podcast.
Excellent.
And today we're talking about prolapse.
Yeah, this is dear to our heart, isn't it? Because prolapse is part of the work of every obstetrician and gynecologist, from prevention right up to diagnosis and treatment. And, I remember when I probably first did my training, the extent to which the physiotherapists had led the way in this field was not known, certainly not known to me. But in the years since then, I think it's broadly known in obstetrics and gynecological circles that pelvic floor physiotherapists have really led the way here, certainly in prevention and in non-surgical treatment and in the recovery from surgical treatment. That relationship is now just fully routine, and it's my view that anyone at risk of prolapse or experiencing prolapse should be treated by a physiotherapist as well as their gynecologist.
What about if we start, because there are different types of prolapse, and I don't know, 2 experts in the room, who would like to describe what a prolapse is?
You fire away.
Oh gosh, I feel under pressure now. I'm a doctor in the house. Well, there's 3 main types of prolapse that we discuss. There's the bladder wall, like the anterior prolapse, otherwise the cystocele. So this is where the bladder wall might flop down onto the vaginal area. There might be a cervical prolapse, and that where it can drop down. And then there's the bowel, where the bowel area can drop forwards into the vaginal area. So that's very broad speaking, but there's the 3 types: the anterior wall, the posterior wall, and then the cervical prolapse too, uterus dropping down.
Yeah, is that
oh, absolutely.
how you would describe it? Yeah.
That's absolutely how I would describe it as well. And the only thing I would add is that it's pretty common that if you've got one, you've got a degree of the other. They don't often exist in isolation. And especially as you get older, I often say that if we think of an analogy is to think of the vagina like a house that's got a front wall next to the bladder and a back wall next to the bowel and a ceiling, which is the cervix and the uterus. And just as if the entire back wall of your house fell down, the whole house might fall down. So if you get a big enough prolapse of the back wall, then the ceiling will fall in. And if you get a big enough prolapse of the front wall, the ceiling will fall in. And it's very common when we think about the causes of prolapse in our community that the sort of damage that's been done to the pelvic floor is unlikely to have just affected one little spot of it.
I went to RANZCOG. So for people who aren't Australian, RANZCOG is the governing body of obstetricians, and they have a whole heap of information for the public. And I went to their site to look up pelvic organ prolapse for the public, what information they provide. It explains what it is, but it really is targeted towards older people, older women.
Yeah. And to establish disease, so there's not much about prevention there.
Yeah,
that's mostly about the surgical treatment of established disease.
Kath, is prolapse an old person's problem?
Absolutely not. So pregnancy and postpartum are one of the biggest risk factors for prolapse. And then, so if we look at the incidence of pelvic organ prolapse throughout our lifespan, there's a spike of issues that happen around pregnancy and childbirth. And then it plateaus out a little bit, and then the next spike happens around menopause. So they're the two life stages where we're more at risk of these issues. And I do just want to say early on, the term prolapse can be quite scary. But there's a lot of different degrees of prolapse. So there's grade 1, grade 2, grade 3, and grade 4. Like they're the main ones where grade 1 and 2 might not even be symptomatic. And it's only when it's the prolapse gets to a certain stage where you start to feel the symptoms. And the majority of prolapses out there are asymptomatic, and they've recently reclassified it so that to be classified as a prolapse, it needs to be symptomatic as well as structurally there's an issue.
I think that's super important. I don't know how we would do it, but if we somehow were able to examine everybody who was 55 and had had 3 previous vaginal births but had no symptoms, then it's not terribly important if they've got some laxity to the anterior vaginal wall or some descent of the cervix to the middle of the vagina with a push. It's relevant if it's doing something to you, if it's causing urinary problems, if it's uncomfortable, if it's hanging out, that's relevant.
And to put it into context, as we age, everything changes. So we might have, gravity has its way. Yeah. So we might have more wrinkles. Our boobs might have dropped down a little bit. So there's that extra potential laxity in your pelvic floor muscles that, and not just the muscles, but the fascia and the connective tissue. So it is that laxity and that movement is also a natural part of aging. And that's why it's great they have reclassified what actually prolapse is.
And I know that listeners, that they're either pregnant or they've had their baby, and they might be really interested in this. But if we're talking mainly about it happening around sort of menopause, it becomes very difficult, doesn't it, to know why it's important right now. But there are different things that we can do right now during pregnancy and childbirth to help prevent it. Is that your thinking, Kath?
From what I believe, this is where research is pointing in the last few years. It's a really exciting area because there is more of a preventative model around treatment. So it's not just a matter of waiting to have a prolapse and then having to treat it. So there's a lot more discussion around what can we actually do and what's research showing us in terms of how to prevent prolapse. So I guess that's what we're going to chat about today as well, I'm sure.
So Pat, are some people more prone to prolapse?
Definitely they are. Some of those things are what we call modifiable risk factors and some are not really modifiable risk factors. So, for example, in our genes, some people's tissue is just saggier than others, and that might be something that's really obvious from your family history. Your mother might have had a prolapse repair young in life. Every woman in your family older than you might have had a prolapse. That's relevant. But it's not really. It's not something we can actually just do something about. We're stuck with those genes, but we can do things to help prevent that becoming disease one day. If we look at pregnancy stuff, there's definitely a connection between having a lot of babies, having a lot of big babies, having those babies difficulties like the birth needing to happen via forceps. And then there's other things like really important things like body weight, the development of a chronic cough. So the main reason smoking's bad for all the tissue in your body, but one of the real things smoking will do is you'll eventually develop emphysema and a chronic cough. And if you didn't have a prolapse already, you probably get one once you're coughing all day. And people who are chronically constipated and sit there on the toilet all day pushing, it's not good for prolapse either. So one of the problems with those things is all pretty common. If we look at, being a woman in the first place and having some babies, that can be enough. So it's why it's not rare.
And some women who don't have babies still get prolapse.
Yeah, absolutely. Yeah. So some of it's about tissue strength. And I've certainly treated people who've had no babies and have developed significant prolapse at a young age. What
about people who like to lift weights? I like lifting weights. I don't want to get a prolapse.
Well, that's a good question for physiotherapists because there's, I think one of the things that we really need to be teaching people is how to lift safely.
Yes. Look, I quite regularly do these research updates discussing all these things. And from what I believe, weightlifting is not a risk factor, but also I don't know if research has been done on this. Like weightlifting means such a different thing to different people. Are we talking about the extremes of weightlifting where you're needing to wear a belt and learn how to control your breathing, or are we talking about just lifting a couple of kilos? So I don't deal with any women that are at that elite weightlifting professional stage. So I can't comment with that. But in general, weightlifting is encouraged during pregnancy. It's great for strength training, great for bone density. My general recommendation is be able to breathe through the exercise. So you're not having to grunt and push down through that pelvic floor area.
This is during pregnancy?
Yeah, during pregnancy, absolutely.
So we've talked about who's prone to prolapse, but we need to really dive deeper on the types of births that people are having and whether that has an impact. Kath, have you got the first start to that question?
Yes, well, I'll leave the birthing side of things to Pat because that's obviously your area of expertise. But it is exciting, this, because as I said at the start, there is more and more we can do to prevent it. There's biggest risk factors that we're finding with pelvic floor issues after birth and in particular prolapse is a longer stage of second labour, so a longer pushing phase. And I'd love to know, Pat, what you consider long, but from what I believe, I don't think there is an actual defined time in the literature in terms of what causes pelvic floor issues, but between 90 minutes and 2 hours is generally considered on the longer side. But that has definitely had a link with pelvic floor outcomes. And you can imagine why, because the longer you're pushing, the more that the pelvic floor area is on stretch, the more the nerves on stretch. So it makes that recovery a little bit harder.
So not necessarily whether a birth is via forceps or rotational forceps. It's more the pushing, do you think?
Oh, well, absolutely. Forceps is another big risk factor, more so than vacuum is. And I feel like I'm stepping over the mark here.
No,
you in the room, Pat.
No, I'm very because see the physios, lead the way in sort of knowledge of the evidence, but also the practicalities. As the obstetrician, we're often saying, well, we've got to get the baby out one way or the other. Yeah, we're happy and familiar with the use of instruments to safely do that, but we can't get away from the fact that that does change the prolapse risk.
And I think from avulsion, muscle avulsion is a big risk for prolapse. And there have been recent studies to show that, like, if you compare forceps with vacuum has a lot less risks in terms of pelvic floor issues postpartum. So if you had a choice between vacuum and forceps from a pelvic floor perspective, vacuum would be much more favourable. But I know it's not all just about pelvic floor. When you're in the thick of it and if you need to have an instrumental delivery,
Yeah.
obviously, Pat, there's other considerations.
That's right. So we've got to look at the way that we're most likely to be able to get the baby out. Not everyone's suitable to have a vacuum. Certainly people who do a lot of vacuums, one of the reasons why they do it is it's kinder to the pelvic floor, kinder to mum. It's less kind to the baby. Forceps sound horrible, but the vacuum is actually tougher on the baby than the forceps are when they're used properly. So there's a lot to consider at the time.
Why are you saying it's harder on the baby for a vacuum?
Oh, it just sort of bruises the head.
Yep.
Whereas the forceps go around the head and really put force on the bones of the head, not the soft tissue.
I know somebody listening to this would go, well, I'm just not going to birth vaginally at all. Like if this is what's my future, like, am I better just to opt for a cesarean? And I know we get this question asked again and again. And anyone listening to this, I bet they picked this topic up because they've had a prolapse after birth, or they're worried about prolapse. So what's our stance on that?
It's a very good question.
Before we go into that question, there's just one more, because I think we would definitely need to answer your question, but there's one more thing around birth, which I think we should bring up. And this is how there is some really exciting emerging information, how we'll take it one step back. Overactive pelvic floor or pelvic floor muscles that have difficulty relaxing. So Pat mentioned it at the start with the chronic constipation. That has been found to be a risk factor for instrumental delivery and a prolonged pushing time. So if we can help to relax the pelvic floor during birth, and there's a few ways that we can do that, but there's some great research showing that helps to reduce second stage labour. So if you can identify that you've got chronic constipation, then I would recommend you go and seek pelvic floor assessment. Or if you've got overactive pelvic floor or high tone muscles during pregnancy, go and have that pelvic floor assessment and work out how your pelvic floor is functioning. Because there's some exciting research to show that a low dose epidural, or I don't know what you call them, walking epidural, can help to potentially relax the pelvic floor, and that can have potentially some favourable outcomes with pushing phase and reducing second stage labour. So that's really exciting.
And you've said that before, haven't you? Because, we've talked about epidurals and how people fear an epidural and the cascade of intervention that can come of that. But you've often said sometimes an epidural is the very thing that helps everything to relax for the next stage of labour to go well. Absolutely.
And that's, every obstetrician has seen that, dozens of times that someone with a huge amount of excessive pelvic floor tone will actually push much better with an epidural.
Yeah.
And epidurals are very different compared to when a lot of the research was done around them. Isn't that right? 10, 20 years ago?
Yeah, the doses were higher and the motor blocks were stronger. Yeah.
And then to take that one step further, there's a lot of women who are listening who might have had endometriosis or chronic pelvic pain. And I think they're an important group of women too, where that proactive pelvic floor support may help with those during birth.
So you're saying that they often, because of that pelvic pain, they have like a hypertoned pelvic floor?
Absolutely.
Yeah.
Yes.
Yeah. And our understanding of this is really just beginning. I think it's one of the real reasons why a pelvic floor physiotherapist should be part of the care team for women with chronic pelvic pain or a diagnosis of endometriosis, because if your pelvic floor is too tight, that may actually explain a fair bit of your pelvic pain, a fair bit of your pain with intercourse. And then your endometriosis is successfully treated and you're pregnant, and then there's even more evidence that being able to control the pelvic floor tone using pelvic floor physiotherapy techniques can actually improve birth outcomes.
I'm going to ask that kind of obvious question that's there, is that, if I can't control that hypertoned pelvic floor, I can't control how long my second stage of labour is, how long I'm pushing for. I can control how I have a baby. Yep. Why wouldn't I just choose a cesarean and reduce my risk altogether about having a prolapse?
Well, it's a good question. Unfortunately, it doesn't reduce your risk altogether. So prolapse is multifactorial. it's not just about your birth experience. So having your babies by cesarean section does not eliminate your risk of prolapse. For most people, the benefits of vaginal childbirth outweigh the risks, and there aren't enough benefits to plan cesarean section to make it a realistic or sensible choice for most people.
All right. And Kath, would you agree?
Yeah, absolutely. And I will just also, you mentioned we don't have any control over the second stage labour, which potentially to some degree, absolutely. But on that pelvic floor topic again, there's some exciting research to show how perineal massage and pelvic floor muscle training can help to reduce risk of that second stage labour, reduce of forceps delivery, so instrumental delivery, and reduce risk of third and fourth degree perineal tears and episiotomy. So it's exciting, because there is actually quite a bit we can do proactively to support our birth.
Can you just briefly, I know that that's probably its own topic, but could you just briefly describe what perineal massage is?
Yes. Now, I love this topic because for me and for the way I teach, perineal massage isn't about getting in there and stretching that perineum. So for anyone listening, perineal massage is designed to help relax the perineum so that it's got that some more beautiful movement. So when the head descends, it can make way for the baby. So it's opening up the birth canal. Like when we perineal massage, we are putting that perineum on stretch. So let's take one step back. To increase a passive muscle length for anyone, we'd need that muscle to be on stretch for hours and hours and hours every day. So what we're thinking is happening is by doing this perineal massage, it's not about passively stretching that muscle and getting that muscle longer. It's about learning how to actively let go of muscle tension. Do you know what I mean? So if you've got a headache or neck pain, you know how we often hold our shoulders up a little bit higher and we develop that tension around our neck muscles? We can actively let go of that tension and relax our shoulders down, and that lets go of that active tension. It's not a matter of having a nice massage in your neck and getting those muscles longer physically. Does that make sense?
Yeah.
So for me, perineal massage is all about it's that awareness of the pelvic floor and learning how to let it go and let go of that active tension. And that's where I think this is beautiful when combined with some hypnobirthing or breathing techniques or affirmations or whatever it is that helps you to focus on the breathing, because it all sort of works together. Our diaphragm works with our pelvic floor. So if we can learn how to relax and let it go to open up that birth canal so that the baby's head can go down. Because that was the one thing that put me off doing perineal massage 10 years, nearly 11 years ago with the birth of my first baby. I thought, I don't want to be getting a stretch down there that's going to last forever.
Yes.
But that's not what it's about. It's letting go, learning how to let go of the muscle tension.
We actually, our physio at our clinic, all our patients have an antenatal screening appointment with Belinda, which is really fabulous. And she introduces them to the idea of perineal massage, and she has appointments where people come in with their partner so she can teach them, you know, the technique, because it can be a bit daunting. And yes, you can look at diagrams and work it out from there, but sometimes it's that feeling, like you're saying, like actually getting to the point where you know what letting go feels like. And I think that's important.
And I like to call it perineal preparation, because I personally don't think we have to get in there and massage to get the full benefit. For example, knowing how to relax your pelvic floor, this is what I recommend all my members do. If you get yourself into an uncomfortable situation, our whole body tenses up, doesn't it? What happens to you when you get into a cold shower? What does your whole body do?
Same.
It tenses up. I recommend a 30-second cold shower at the end of your shower, and practice your breathing techniques. Practice relaxing through your pelvic floor, because if you can do that in an uncomfortable situation and it becomes a bit more of a habit and you can switch it on or switch it off rather, at a moment's notice. I think that's what's important rather than, as I said, the physical massage. But the physical massage can actually help to get that awareness. But not all women might need that or want to put their fingers down there or their partner's fingers or whatever it might be. So I think there's other ways of becoming aware of your pelvic floor muscle tension.
Yeah. That's so true. And the whole idea of childbirth for so many people is it's a fearful event, and it's working on, if you're saying it's learning how to relax in that fearful event, it's learning about, well, what are the fears that you have? We do talk about fears in our program, like it's a whole module in itself, isn't it? Because there's common ones.
Absolutely. All right, I've got a question for Kath. Let's say my patient has been the ideal joiner from a pelvic floor point of view. They've seen a pelvic floor physiotherapist during the pregnancy, and they've learned a technique for perineal preparation, and they have also learnt some good exercises to maintain bladder continence afterwards. Then the birth happens, and whatever happens. Baby, mum and baby are well. In the first 6 weeks after the baby comes, are you supposed to be resting or doing something?
This is exciting because, again, there's more research emerging about this. Those first 6 weeks are all about protecting this area. So in this situation, resting, maybe doing couple of small little lifts at the pelvic floor, doing a little lift before you sneeze or you cough. But it's not a time where you want to be doing heaps and heaps of pelvic floor exercises, and that's what research is pointing to. The more we can rest, a few beautiful, gentle activations. Yeah, and it makes sense, doesn't it? If you had a knee surgery, you would not be doing heaps of knee exercises in those first 6 weeks.
Good.
You'd be doing beautiful, gentle activation.
Yeah. What some people don't understand is what activation is. So, yes.
Yeah, and I'll take that one step further. So when I say rest, I don't mean lying down all day, every day. Relative rest. So that might include some bursts of horizontal rest throughout the day. So horizontal rest takes the weight of gravity off the pelvic floor. If we think of that pelvic floor area like an elastic band that's stretched during childbirth, it stretches up to 300%. It's amazing, 3 times its length. We want that natural recoil to occur as much as possible, like an elastic band. We don't want to keep putting that area on stretch. And that's where horizontal rest is really powerful in those first few weeks. So bursts of horizontal rest, like 5 minutes here, 10 minutes there, to deload that pelvic floor area. And then I think another big one is walking, just walking, building that up slowly. Because I know personally, and from members, I went for a longer walk at 2 weeks postpartum, and that's when I developed my prolapse symptoms. Like I did too much too soon without building up gradually. So 5 minutes week 1, bursts 5 minutes. I don't mean 5 minutes of walking and then that's it, but 5 minutes here. And then second week, 10 minutes, 15 minutes, 20 minutes week 4. So by the time you get to 6 weeks, that's 30-minute bursts of walking, and combining that with some horizontal rest, deloading that pelvic floor. I think that's really powerful in those 6 weeks. We have got the rest of our life to get fit and strong and active again. There's no rush. You could be the fittest, strongest woman in the world, but if you've just had a vaginal birth, everything's stretched, and it's not just about the muscle stretching. It's the fascia. It's that connective tissue. I've said this before. It's like when you eat a piece of steak, it's not just red muscle. It's, you've got all the white sinew bits, and that's what we want to protect in these first 6 weeks.
Good answer. That's the sort of detail people are looking for, right?
Well, I went for a little walk that ended up being like 2 hours or something. Remember when it was like second week after my third Caesar?
Yeah.
Because it just, sometimes you do feel pretty good.
Yeah. And it feels nice to be outside.
And it feels nice to be outside, and you forget that you've just had a baby. So, yeah.
And unfortunately, there's no grey area with symptoms. You either feel good or you've got symptoms.
Yeah.
And so it is tricky. And I know it's nice to get out and about. But look, if you were stuck out for a long period of time in those first few weeks, even finding a park bench, having a little sit down, just have a bit of a break, or go to a park and have a lie down on the grass with your baby. So you don't chunk up the exercise rather than just one long extended period.
Perfect.
Say someone has just had a baby and let's divide it up into immediate sort of prolapse concerns and symptoms, and then we might talk about long-term issues. But say someone's just had a baby, what are the first signs and symptoms that they might have a prolapse?
You're listening to The Kick with Dr. Pat and Brigid.
How many times have you Googled something about your pregnancy?
When I was pregnant all the time, Dr. Pat.
Yeah, we get it. You may be confused or overwhelmed. It's normal to want information, but where's the reliable stuff from experts?
Yeah. Now, if you like our podcast, Dr. Pat and I have developed an online program to help guide you through whatever stage of pregnancy you're at.
It's taken us literally 2 years to put it together.
2 long, hard years, wasn't it?
But, it is a game changer in how pregnancy information is given.
Now, how it works is you get to sign up at whatever stage of pregnancy you're at. So you could be pre-pregnant, in your very early stages of pregnancy, late pregnancy, preparing for birth, or maybe you've just brought your baby home. And you get lots of information around that. And then you also get to join our closed Facebook group.
We've called in all our contacts too. So we've got a dietitian, anaesthetist, physiotherapist.
Sonographer.
Yeah, who else? Paediatric nurse, obstetrician, mother of 4.
Oh, just all the people you need to hear from.
So if that's you, come and join us at www.growmybaby.com.au.
Yeah, so let's say we've done all of these preventative things and yet here we are. Then someone might come back and say, look, there's a definite bulge. And in the postpartum situation, sometimes that's that the front vaginal wall is bulging down, that the back wall is bulging out, or sometimes most obviously that the uterus itself is distending down the vagina and the cervix is poking out through the vaginal lips at the introitus, the vaginal opening. And, this can be really stressful for people because they think, firstly, that they're stuck with that won't improve. And then they think, well, is that the end of me having babies?
Oh, yeah.
So there can be that immediate or short-term presentation, and it's got a way of managing it. And then there's the people who come back not after 6 weeks, but after 6 years.
All right, let's talk about those people at 6 weeks that might have noticed something that they're not sure of. What happens there?
So you got to be able to sort of see people around about that 6 week postpartum check and say what, and include in that discussion not just the contraception and the plans for next time and how's the baby going, and it's about also address the issue of pelvic floor tone, albeit briefly at that discussion. And if someone brings up an actual problem, then they're going to need a short term solution, and often a solution that is that allows them to still have another baby. So if the cervix is poking out, there's no point recommending a vaginal hysterectomy. I can fix that with an operation. Or what about all the more pregnancy I want to have? So that's where temporary measures like ring pessaries can be useful. The rubber ring that can go in the vagina and help hold things up. But mostly we're looking to the physios.
And so what would you do in that physio appointment, Kath?
I'll just expand on that ring pessary that you mentioned there, because that's also a really exciting area that's expanding rapidly. The pessaries in those early stage postpartum, I think, are having potentially a big preventative role in prolapse management. So it is exciting. So the pessaries might be useful, like you pop it in the morning. This is months down the track, if you wanted to go for a run or do CrossFit and you had symptoms of prolapse, that can be really helpful. If you pop in a pessary, then you're symptom free. You can go and do whatever exercise you want, and then you take it out at the end of the day. So it can be an amazing conservative form of management for women out there with prolapses, so that, this prolapse isn't affecting them day to day. They can get out there and do everything they want. But then in addition to that, then there's all the other beautiful conservative management options out there. So obviously pelvic floor exercises is a big one. General exercises so that we can maintain our weight and strength. Because as we said before, weight is a big risk factor for prolapse, but also for your symptoms. So I've had some women who've managed to lose a little bit of weight and then their symptoms drop off. So general exercises. So that also helps with the mood, the confidence, feeling of wellness, because prolapse, as you said, was really scary and it might affect their mental health. So I think that exercise has some beautiful all-round benefits there. But the other big one we haven't spoken about, or we did touch on, but it's learning how to manage any symptoms, bladder or bowel symptoms with a prolapse. So a prolapse might create a few problems around emptying your bladder. So there might be something called a double void that might be helpful, where you do your wee and then you stand up, you have a bit of a jiggle around, a bit of a move, and then you try again. Or it might be that you need to lean a certain way on the toilet, which can help with full opening of the bladder. So it depends which way the prolapse is sitting. But some women might find leaning forwards helpful to fully empty that bladder, and the bowel as well. Some management strategies around the bowels if they're having difficulty with opening of the bowels and full evacuation.
Yeah, because it would just compound it if they were also constipated after birth, which happens frequently.
Hugely, yeah.
And they've also got a prolapse. So how do they manage that?
There's lots of good advice we can give people around managing the firmness of the stool. So if you can get on things, even natural things like psyllium husks that keep the stool at a consistency so that it can be pushed out without pushing the prolapse down too far. Even the position we sit on the toilet.
Yeah, we're a big fan of the footstool.
Yeah, it's a bit suboptimal. So we just sort of learnt to use the toilet by putting our feet on the floor, but actually our feet should be up a little bit. And these are things that suddenly become highly relevant if something as natural and normal as opening your bowels results in a significant symptomatic deterioration of the sense of prolapse.
And often when we can sort out the bowels, any bladder symptoms improve too. And to take that one step further, like we're hunters and gatherers. Like we used to squat to go to the toilet on the ground. There were none of these modern toilets, and that the way that our bowel is it's perfect for that squatting, and it can open a lot easier. Whereas the modern toilets, it prevents this sort of a kink a little bit. So it can make it harder to pass a bowel motion. And that's where that stool is really helpful. Popping your knees, your elbows on your knees, relaxing through your stomach area and taking some nice deep breaths. In the hospital that I used to work with, in the maternity ward, those stools were like, they just keep disappearing.
Yeah.
I don't know if people used to what happened, but they were hot property, and it's very hard to get hold of a stool in hospital.
Yeah, they might go, this is really good. Where do you get one of these things? I know, right here. I'm taking this home in my little bag that I came with. Yeah. No, our physio at work, basically she would like to give those to people just as gifts. The footstool makes a good birthday and Christmas gift.
And your children will need to use it when they get a bit older too.
Yeah.
Win-win.
Yep, that's right. All right, so that's the sort of short-term prolapse. How successful are the conservative management of a prolapse in that short term? Like, do people resolve? Does a prolapse resolve, or is this something that then goes on?
I think that firstly, I'd say I don't think we've got tons of data on this, and I don't think we've got as much as we need. And the people who've already got a prolapse are already on our radar, so they're easy to treat because they're asking for treatment. I've always been really curious about whether we should be doing more for the people who don't have an immediate postpartum problem to help prevent their prolapse when they're for them to come back 20 years later. And I think I've always thought it would be great if we could have some sort of consensus about what is the peak preventative treatment for somebody who's had 3 vaginal births, but within sort of a year or two of the end of the last pregnancy they still aren't having any symptoms. What can we do for that person? Yeah. Because right now we can't do nothing for them because they don't have a problem that's right in our face.
Yeah.
Yeah.
And in true female style, might just be putting up with a lot of discomfort.
Yeah, plus that person's life at that stage is all about soldiering up. They've got little kids and tons of stuff to do, and they're off doing it. I wonder what Kath thinks about, should you go, it's a bit of a loaded question, but should you go to see a pelvic floor physiotherapist if there's nothing wrong with you?
Post-birth.
Well, yeah, I know this is a biased view, but absolutely. I think there's always something that, like, whether or not you've had a cesarean birth or a vaginal birth, gold standard at 6 weeks, go and touch base with a pelvic floor physio. Unfortunately, we don't offer this in Australia yet. There's some countries that are starting to offer this, in France, and there's one other country that I'm aware of, but they offer this to all women because they can see the benefits long term. And if we think how much incontinence costs the economy every year in the healthcare system, like and I'm not talking about postpartum, but years down the track.
Yeah.
If we could do just a few things in this early postpartum stage, as you said, Pat, like the 3rd and 4th degree prolapses where there's a visible bulge and obvious symptoms, they, as you said, they often are getting the treatment they need and a bit of a holistic management plan. But it's all those other asymptomatic women. What can we do to help us? And a lot of that, I really do believe, does come down to healthy, like, exercise, healthy lifestyle, staying active, not smoking, weight management, all the rest. But yeah, that was a great question. I love that you asked that.
Do many people at that early stage, say they're 6 weeks, 3 months, first year after a birth, and they've got a significant prolapse still, is that a time for surgery or still conservative management?
Yeah, so that's good. Yeah, so that's right. So we've moved on now to the person who's finished the family and they're starting. And exactly when to operate is a difficult question. The treatment for most people with a significant prolapse, and we're not talking about mild asymptomatic pelvic floor or vaginal laxity, or mild stress incontinence. We're talking about people with significant issues. There is a point at which that person will want some management, and the management is basically consideration of surgery, consideration of lifestyle factors, and consideration of pelvic floor tone. So it's a bit of an operation, a bit of a tidying up lifestyle factors, and a bit of physiotherapy. When's the right time to do it? It's such a complex question. People will come back in their 40s with a significant prolapse that they're hating. It's affecting their self-confidence. It's affecting their capacity to function normally in the workplace. It's certainly affecting their sex and sexual function and sexuality. And so how do you say no? Even though the ideal time to operate might be much later on, because pelvic floor surgery, of course, is the major risk is not some sort of surgical complication at the time. It's recurrence. Gravity does not stop applying to your body on the day that I do an operation and fix your prolapse, and the walls of the vagina can fall back down again. So it's kind of nice to do someone's first operation at 75, because by the time they get a prolapse, they probably won't. Sorry, by the time they get a prolapse recurrence, they might no longer be alive, or they might be very elderly and spending a lot of time sitting, and they're not going to come back asking for another operation. But in reality, people come in their 40s, 50s, early 60s wanting and needing prolapse repairs, who that part of their care may be the management of recurrence later on. That's why we try and take a multidisciplinary approach to it, because I see one of the main benefits of the involvement of the physiotherapist is a little bit beforehand, so that the tissue I'm operating on is in better condition, but a lot afterwards as probably the mainstay of recurrence prevention.
And I would just also, if someone is really wanting to have surgery, I would personally sit down with them and find out what's actually really bothering them at the moment, because it might actually be something that is manageable to help then delay any surgery that they require. It might be sex, for example. It's impacting sexual function. Have a conversation around, how is it actually impacting your sex life? Like, is it the fact that we perhaps need to discuss some different lubricants or positioning during intercourse? Or there's some other things on the market, like an O-nut, where it's a ring that you place at the base of the penis, and that can help to improve comfort. So, having a chat to whoever it is that's really wanting surgery, and then finding out what is the actual problem here. Are there any ways that we can manage the person's particular issues to delay? I'm not saying they won't potentially need surgery, but then delay having that surgery to a few years down the track.
Yeah, that's a really good point. I've certainly had patients who have wanted an operation for prolapse because they've got a ring pessary in which holds up the prolapse really, really adequately, and the only time it doesn't is when they take the ring pessary out for intercourse and the prolapse falls out, and then they feel self-conscious and they want the prolapse fixed purely because of an issue related to sex. And then they just weren't aware that some couples will just learn to have sex with the ring pessary still in, and that's fine. It's not unsafe or dangerous or even unsatisfactory, and then problem solved. Didn't need an operation, just need to leave the ring in. I've seen that a couple of times.
And I had a beautiful patient who was like in her 90s, and she wasn't able to have surgery because of her age and whatever it was, and she did have a visible like vaginal bulge that was just impacting her. But she found a great management strategy was actually to have intercourse, because that would help to push the
back
bulge
in
up
for a minute
for her.
Yeah.
So that was her management strategy. Every few days. So it was just so everyone can learn. Yeah, there's different techniques for everyone. I'm not saying that's what you have to go out and do, but
good on her as a 90-year-old having sex every second day. Like, how fabulous. I love that.
I think she did it mostly for prolapse management rather than anything else. But but yeah, it's more about opening up the conversation, isn't it? So that we can brainstorm. I'm
imagining that people come to you because the feeling of a prolapse bulging into their vagina is uncomfortable.
Yep.
And that just doesn't feel good. It would feel like a tampon falling out. Is that what it feels like?
Yeah, it can. Yeah, absolutely. Or it can be a physical bulge that they just don't like the feel of when they're showering, or it could be the sensation that when they move, they feel like something's falling out of them.
But does it cause stress and fecal incontinence?
I think that the modern understanding of that is that if we look at the bladder, that they're probably to a certain degree two separate issues. So as the wall, if you get a prolapse of the front wall of the vagina where the bladder is behind that wall, and as that wall comes down, it will ultimately have some effect on the urinary sphincter mechanism. But if you then go and do an operation and put that front wall back where it was before babies, the stress incontinence, the leaking if you cough and sneeze, is usually still there. And it's because it wasn't the prolapse that was causing that. It was probably damage to the sphincter mechanism that happened at the same time, the vaginal childbirth, but it's not the same thing.
Yeah, right.
Okay. And if we look at the other side, the bowel, I'll be interested to hear what Kath thinks about this, but it seems that there's a form of prolapse whereby it's very, very hard for the woman to empty the rectum even if the stool is soft. Because if she sits on the toilet and just pushes, instead of raising enough pressure inside the rectum to push the poo out into the toilet, all that happens is the prolapse gets worse and the pressure's kind of being pushed in the wrong direction. And some of those people have learnt all by themselves to put their fingers in their vagina and push backwards towards the rectum to bolster the posterior wall and help with the defecation. When you operate on that group and fix the posterior wall, they do get an improvement in that problem, but they don't necessarily get an overall improvement in leakage because, again, leakage might have something to do with the anal sphincter mechanism, which is different.
Yeah.
Am I right about that, Kath?
Yeah, I'd agree with all of that. They can be related, but often they're separate issues. Because the anal sphincter one, that might be more common with like an oasis injury, like a 3rd and 4th degree perineal tear. Potentially it wasn't they're surgically managed at the time of the birth. And they're definitely two separate issues, but they might be related.
Yeah, and they go together in the one patient at the one time.
Yes.
Yeah.
And especially if the issue in the first place was because of a prolonged second stage.
If that was one of the contributing factors, absolutely. So it's why we need to be very careful if we're going to operate on prolapse, that we need to be very careful about what the operation can and can't promise you, number one. And number two, we have to be realistic about recurrence. And then thirdly, we have to operate not in isolation, but as part of a multidisciplinary team, because you don't get the results you're looking for if the person doesn't see the physio, remains obese, or remains a smoker.
Can I move on to subsequent pregnancies? So if someone's got a prolapse, and again, it would depend on the severity, but can they go on and have other babies?
Definitely, yes. And the approach we tend to take about this is to put the prolapse aside for a moment, work out desired family size, work out a plan for the delivery of those other babies. Two schools of thought. Might be nicer to have a section if we've already got a prolapse versus damage is already done. Might be nice to have the babies vaginally. And then regroup after the last baby's been born and make a multidisciplinary management plan then.
Can I share with you both and listeners family folklore in my house, the O'Sullivan house, and that is I'm the last of 7. My mum had 7 children, and she talks about having prolapses. And the prolapse back then, she had to wear a belt or something. This is family folklore, and she's totally got this wrong. But she does say that in my birth she had an immediate hysterectomy or something. Is it possible that the whole prolapse happened at my birth?
Yeah, that's a thing. So that you can get a really severe prolapse that happens immediately after the birth, where not just the cervix but a lot of the uterus is hanging out. And when it hangs right out, it's called proxidentia, and a proxidentia happening immediately after the birth is a thing. These days we'd be less likely to manage that with an immediate hysterectomy and much more likely to manage it with a combined surgical and non-surgical intervention later on.
Right.
And the modern pessaries have replaced those belts and whatnot at being able to push the prolapse back in and keep it in until we've all had a chance to regroup, recover from the birth, and work on a better plan. And
would a pregnant woman have a pessary? Like if she's had a previous.
That's a really good question, and the answer is really interesting. If you've got a really big cervical prolapse where the cervix hangs right out, pregnancy will fix that after about 15 weeks, because after about 15 weeks the uterus is too big to fit down the pelvis. So they're really bad at the start. I say to people, don't worry, pretty soon it's going to come back up. And as the bit of the uterus with the baby in it gets bigger, it won't fit through the bony hole in the middle of the pelvis. So the cervix goes back up, and the pregnancy temporarily fixes the whole thing.
Yeah, right.
And then, of course, it all comes back down again afterwards. Yeah.
Oh, well, it's such a big topic, and I think it's getting a lot of social media airtime. What do you think, Kath?
Yeah, hearing about it more and more, and I think it's great that women are feeling comfortable to talk about it and talk about their experience.
And also I think it raises that, like as Pat keeps saying, it's a multidisciplinary approach, but the importance of having physio care, knowing more about your body, knowing what's normal, what's not normal, what you can do proactively to help manage and prevent a prolapse. Kath, thank you so much for joining us. As we've mentioned, you've got your podcast, the Fitness Podcast.
It's rebranded actually. It's the Pregnancy, Birth and Recovery Podcast.
Excellent. Nice. Okay. Sorry about that.
We've got to get the name right.
Yeah. And
Pregnancy, Birth and Recovery Podcast.
And what's your Instagram handle, Kath?
At Fitnessed Mama, FITNESTMAMA.
Kath, would you join us on our myth or fact? Sometimes at the end of the podcast we do a myth or fact, and it's a bit of fact. It's a bit of fun, but I think we've already answered this. But the reason why I put this in here is because sometimes Dr. Pat comes home, very rarely talks about how it all went, but sometimes you'll come home, Pat, and you'll say, yes, however, the pushing wasn't effective. The woman in labour, she didn't push effectively.
Yep.
And sometimes that's a fear. So my myth or fact is, if you push too hard in active labour or as your baby is crowning, you'll cause a prolapse. Myth or fact?
I think it comes more down to the position. And again, I haven't been in the birth suite. This is all for me, research and study. So I'll leave it up to Pat. But from what I believe, it's like in a squat, like where it's got that direct force of gravity, that might not be so helpful on the pelvic floor area. And also if there's an assisted push through the abdominal area, I don't think that's done much anymore. Is that right, Pat?
No, we don't do much of that, but certainly position is thought to be important. And what you were saying before, I think, that the data supports a correlation between prolonged second stage and the development of prolapse. Then I think, what have we really got to help make people's second stage be shorter? And I think it's all of those things, like using different positions, coaching, and realising that people can only push for so long. So that the things that I believe are effective in keeping the second stage manageably short is that you don't start pushing the minute you're fully dilated. You wait until the head comes down, you feel an overwhelming urge to push. Otherwise, you're going to wear yourself out, and you're much more likely to get to the end of whatever time limits are sort of in place in that institution, and more likely to have a instrumental. But if you don't start pushing until your body really feels like it can't help but push, then you've got a reasonable chance of pushing the baby out before you're exhausted.
Yeah, that's another thing you say. She started pushing too early. Everyone was encouraging her to push, and she wasn't really ready to push.
That is a thing. Yeah. So I think in the woman who doesn't have an epidural in place, she will know when her body's saying you got to push. And if you do have an epidural in place and it's taken that feeling away, then we probably should be doing more of an additional vaginal examination at that point, and not getting the woman pushing until we can feel with our fingers that the hair's nearly out.
Good. I've got a question for you, Pat, about breathing and pushing. What are your thoughts around breathing the baby out? And I don't know if I should mention names, but a particular thing that's being taught.
I think controlling our breathing is a really, really effective way to manage stress and anxiety in any sort of scenario. So learning how to control our breathing in the birth process is something to concentrate on, so that you think, okay, I'm going to control my breathing, slow my breathing down. I'm trying to remember my training. What did they tell me about relaxing the pelvic floor and so all those things. I think that's all a great idea. But sometimes when people talk about breathing the baby out, they mean having a baby without pushing.
Yeah.
And I think that it's very difficult to have a baby without pushing if it's your first baby.
Well, I think that it's not defined further. So I think from my understanding, and we've talked about this before, but the breathing the baby is when the baby's coming out.
Yeah.
But pushing to get it there is important.
Yeah. So there are coaching techniques that you can do to help people ease the head out rather than blast it out. And as the head crowns, the overwhelming urge to expel the head is near irresistible. So what you're doing by this stage is telling people not to push, or to push much less strongly than they have been so far, and concentrating on breathing and puffing instead of pushing is a really valuable thing to recommend at that time. We know that doing that and easing the head out reduces the incidence of perineal trauma and tears. What we don't really know is whether it reduces the risk of clinically significant prolapse years down the track.
That's right. The jury's out in terms of the large reviews. But along with that, there's also the perineal protection consideration, isn't there? The manual pressure on that area, like as you said, so to control that explosive, reduce any explosive force. I'm not sure whether that was a myth or a fact.
Well, it's another grey area one. Yeah, good question though.
Yeah. That's right. Good. All right. Well, Kath, thank you so much for joining us today. We've really enjoyed your input into this topic. We'll have you back again to talk about other topics. But yes, thank you for listening, everybody.
Pleasure. Thank you for having me.
Thank you for joining us. It's been terrific.
Thanks, everyone, for joining us, and we'll see you again next week.
See you next time.
Okay. Bye for now.